Hello, everyone. Thank you for joining us today for this educational webinar organized by ONSIA Community. So the focus of this webinar today is on the role of nutrition to prevent cancer and its recurrence. But before we get started, let me introduce a little bit ONSIA Community for those who don't know us yet. So my name is Françoise Vamek. I'm the co-founder of ONSIA Community. ONSIA Community is a cancer foundation committed to humanizing cancer care. Our mission is to raise awareness of the positive impact of integrative oncology and to support the development of complementary cancer care across the world. So we facilitate the development of these centers next to leading hospitals to provide patients with a non-clinical environment, a safe and cocooning, healing environment. So this center meets all the needs of people living with cancers to give them the strength to fight against cancer. So people can access in these centers to evidence-based therapies like physical activities, stress reduction with mindfulness, for instance, and nutrition counseling. And that's exactly why we're here today, to understand the key role of nutrition to prevent cancer and recurrence. And so for that, we have the great opportunity today to welcome one of the leading voices in integrative oncology, Professor Donald Abrams. So we are very delighted to welcome you today. Dr. Abrams is the past Chief of Hematology Oncology Division at Zuckerberg San Francisco General Hospital. He was an integrative oncologist at the USF Osher Centers. He's now Professor Emeritus of Medicine at the University of California, San Francisco, so UCSF, and he was president of the Society for Integrative Oncology in 2010. And he continues to lead the field today. So first, Dr. Abrams was a pioneer in AIDS oncology. He treated cancer patients during the AIDS epidemic for 25 years. And since 2005, he has been providing integrative oncology consultations to cancer patients. So he was also a pioneer not only in treating the disease, but also in caring for the whole person, addressing all the dimensions of health. So we met for the first time at the SIO Congress in Oxford 6 months ago, and he immediately accepted to participate in this webinar. Choosing to speak about nutrition is, I guess, his true passion. So before we begin some practical details, the webinar will last for 1 hour. This webinar is being recorded, and a replay will be available on our website. After the presentation, Dr. Abrams will answer your questions live, and please submit your questions using the Q&A button and not the chat button. So I will now give the floor to Dr. Abrams. So thank you so much for being with us today.
Merci, Françoise. It's a pleasure. Good morning, good evening, good afternoon, wherever you are. I am going to talk today about nutrition and cancer do's and don'ts. When I see a patient here at the Osher Center for Integrative Health, I tell them that cancer is like a weed and someone else is taking care of their weed, and it's my job as the integrative oncologist to make their soil as inhospitable as possible to growth and spread of the weed. So I do that by looking to see how they fertilize their garden, that is what they eat and what supplements they take. And what I use to have my conversation are the guidelines from the World Cancer Research Fund, American Institute for Cancer Research. And they are guidelines for cancer risk reduction. However, number 10 says, after a cancer diagnosis, follow the guidelines above. So it does make sense for me to review these guidelines with people who already have a cancer diagnosis. So from the American Institute for Cancer Research, World Cancer Research Fund, the do's are, I'm also highlighting the difference between the guidelines that were published, a 500-page volume in 2007 versus the update in 2018. 2018, the guideline is to be a healthy weight. We now know that the American Institute for Cancer Research estimates that obesity-related excesses of these 7 cancers account for 115,000 preventable deaths a year in the United States alone. And the largest number is for postmenopausal estrogen receptor positive breast cancer. But interestingly, 50% of endometrial cancer is related to overweight or obesity. The rest of the overweight, obesity-related malignancies are along the gastrointestinal tract, except for renal cell carcinoma, which interestingly, 1/4 of the patients are related to overweight or obesity. So we know that weight probably increases the risk of these additional cancers as well, with a suggestive increased risk for cervical cancer. Interestingly, being overweight decreases the risk of premenopausal breast cancer. Well, how does that work that fat increases the risk of cancer? As we know, fat produces estrogen, and estrogen certainly drives those estrogen receptor positive breast tumors as well as endometrial carcinoma. And body fat secretes cytokines that promote inflammation. And as you know, once we're inflamed, that impairs the body's immune system. So much of cancer treatment today is enlisting the immune system to fight off cancer. The fat produces the cytokines which impair the immunity. And we saw this clearly in COVID in this country, where many of the patients who died were in fact obese and overweight because of impaired immunity. Probably, I think the most important thing is that body fat triggers insulin resistance, leading to elevated levels of insulin and insulin-like growth factors, both of which promote cancer, and the growth factor is a growth factor for cancer cells as well. The other positive guideline is to eat a diet rich in whole grains, vegetables, fruits, and beans. And this was moved up this year. I tell my patients that it's important to eat more plant estrogens, including soy foods, and there are some phytoestrogens in flax seeds as well, which also provide omega-3 fatty acids. My go-to vegetables are the cruciferous vegetables. Flowers grow in the shape of a cross. So broccoli, cauliflower, and Brussels sprouts jump to mind, but there are also cruciferous roots and green leafies: cabbage, kale, collard green, bok choy, and arugula. These all contain a chemical so potent at reducing the risk of cancer, sulforaphane, that we started to look at it in the treatment of prostate cancer. They also contain something called DIM, which changes a woman's estrogen from the type that fuels estrogen receptor positive cancer to the type that doesn't. So I believe we can never eat enough cruciferous vegetables, and I eat broccoli, tofu, and rice for either breakfast or lunch. Season with ginger, garlic, onions, turmeric. Turmeric, the first I ever heard about turmeric was at a conventional ASCO meeting, the American Society of Clinical Oncology. Investigators at Ohio State University have a mouse model where the mice are genetically programmed to develop colon cancer. And if they fed them a turmeric-enriched diet, they did not develop colon cancer, because turmeric is not absorbed from the upper GI tract, and it can make its way all the way down to the colon for local chemo prevention. Second only to cruciferous vegetables in the potency of its cancer-fighting chemicals is green tea. Tea is the name of the beverage brewed from the tea leaf, the Chinese camellia, or the Camellia sinensis, and it's graded on how oxidized the leaf is before the beverage is brewed: white, green, oolong, black, and pu'er. And the only two with the cancer-fighting chemicals are white and green. I drink 4 cups of green tea every morning. Nuts. People are concerned about nuts because of salt and fat. I'll show you in a moment, nuts are beneficial and can decrease the risk of a number of different cancers. Now, the European Prospective Investigation into Nutrition and Cancer, I have to applaud the Europeans, because you have done much more positive work on this question of the interaction between diet and malignancy than I see that we have done here. So the EPIC study group did a systematic review of 110 different studies that have emanated from this research. And they looked at diet-related exposures and the incidence and mortality of the top 4 cancers. So for colorectal cancer, higher consumption of fruits and vegetables combined was related to a lower risk, 14%. And a similar finding was seen for fiber consumption. Nut and seed intake also decreased the risk in women quite significantly. For breast cancer, low consumption of fruit and vegetables increased the risk with a hazard ratio of 1.76. The highest protective effect in breast cancer was from leafy and fruiting vegetables and raw tomatoes. Total dietary fiber and vegetable fiber lowered the risk, but not fruit, cereals, or legumes. Now, recall that we cannot do randomized placebo-controlled trials in nutrition because you can't randomize this half of the room to tofu for the next 50 years and this half, to placebo tofu? Many people think tofu is placebo anyway. So we have to depend on these epidemiologic studies. In lung cancer, eating fruits and vegetables lowered the risk, 6%. Fruit all alone also protects, but 2 other studies didn't show any benefit from vegetables. So lung cancer, I think, is tobacco is the big issue here. Prostate cancer, only 1 study showed no association between fruit and vegetables and risk, and that was later disconfirmed in a later study that did show a protective effect of fruits, no association between dietary fiber and prostate cancer. Well, what about soy? One of the major questions that I'm asked by my patients that I see here at the Osher Center is, can women with breast cancer safely consume soy because of its phytoestrogen content? The Life After Cancer epidemiology study done by the Kaiser Permanente group followed almost 2,000 breast cancer survivors with an estimated follow-up time of 6.3 years. Soy intake levels comparable to those consumed in an Asian population, i.e. 1 serving of a whole soy food a day, seem to reduce the risk of recurrence in women, even those treated with tamoxifen. Soy does not appear to negate the effects of tamoxifen, which was a concern. These studies of soy decreasing the risk of recurrence have been reproduced in the Shanghai breast cancer survival study, as well as the Women's Healthy Eating and Living study, all of them confirming the benefit of soy in women with breast cancer. And I mentioned nuts. This study examined the association of nut consumption, including both peanuts and tree nuts, with overall and disease-free survival in 3,500 long-term survivors from the Shanghai breast cancer survival study. Median follow-up of 8 years, 374 deaths, including 252 related to breast cancer. The women who were regular nut consumers had higher overall survival, 93% compared to 89, as well as disease-free survival. There was no variation noted for the type of nut or their hormone receptor status, and the authors concluded that promoting this modifiable lifestyle factor should be emphasized in breast cancer survivors. So soy and nuts, in addition to cruciferous vegetables. Remember, the diet is not individual components, but a whole picture, many different components alone together. So from the World Cancer Research Fund, American Institute for Cancer Research Society, let's look at the don'ts. So in 2007, the guidelines said avoid sugary drinks, limit consumption of energy-dense foods, particularly processed foods high in sugar, low in fiber, and high in fat. And in 2018, this guideline was split into 2 separate components, and they actually called out fast foods by name. Limit consumption of fast foods and other processed foods high in fat, starches, or sugars. And I like this quote: processed foods high in fat, starches, or sugars embody a cluster of characteristics that encourage excess energy consumption, i.e. calories, for example, by being highly palatable, high in energy, affordable, easy to access, and convenient to store. So processed foods, I read my colleague Robert Lustig's book, Metabolical. Robert is our pediatric endocrinologist at UCSF who fights the war on childhood obesity and sugar. And in the book, Metabolical, he blames the deterioration of our health as a nation over the last 50 years to overconsumption of processed and ultra-processed foods. So again, a study emanating from Europe looked at the Nutri-Score, scoring each food, calculating using its 100-gram content in energy, sugar, saturated fat, sodium, fiber, etc. A higher score is a lower quality of the food. They looked at 500,000 adults in the EPIC study. 10 European countries enrolled patients from 1992 to 2000. So the median follow-up at publication of this study was over 15 years. Nearly 50,000 invasive cancers were diagnosed, mainly breast, prostate, colon, and lung. And high scores, i.e. diets that are not ideal, were seen in France, Germany, the UK, and Sweden. And low scores were basically the Mediterranean group, Greece, Italy, and Spain, and then an outlier being Norway. So the higher score, meaning the more processed food, was associated with a higher risk for all cancers, 7% increase with a statistically significant p-value. Higher scores were associated with a higher risk of colorectal, hepatocellular, and postmenopausal breast cancer in women, and lung, and a borderline increase in prostate cancer in men. There are also trends towards higher risk of stomach and other upper aerodigestive tract cancers. So again, this was supported by a study from the UK Biobank, a prospective evaluation of nearly 200,000 participants, 45% women. They looked at mean ultra-processed food consumption, 23% of calories in the total diet. And I just want to applaud the UK because recently a study came out in the US that adults here consume 55% of their calories from ultra-processed foods. And children under the age of 18 consume 62% of their calories from ultra-processed foods. So we have a big problem. 23% looks pretty low. But during a median follow-up of 10 years, 16,000 developed cancer and there are 4,000 cancer deaths. Every 10% increase in ultra-processed food consumption was associated with an increased risk overall, 2% of cancer, and specifically ovarian cancer here. Every 10% increase in ultra-processed food consumption was associated with increased risk of overall mortality, ovarian cancer mortality, as well as breast cancer-related mortality, and these are more significant. Participants with the highest compared with the lowest ultra-processed food consumption had higher incidence of overall cancer, as well as brain tumors, and a lower incidence, surprisingly, of head and neck cancer. Now, a systematic review of ultra-processed food and cancer was based on 8 retrospective case control studies and 3 prospective cohorts. 9 of these 11 studies reported a significant positive association between ultra-processed food intake and all assessed cancers except prostate cancer after adjusting for obesity and total energy intake. Again, a 10% increase in ultra-processed food was associated with an increased risk of overall cancer, which is higher here, 13%, and breast cancer. Higher intake of ultra-processed food was associated with increased risk of colorectal and pancreatic cancer as well, with modest associations found for chronic lymphocytic leukemia and brain tumors. And again, the investigators say that the available evidence suggests a consistent association between intake of ultra-processed food and the risk of overall and several cancers. So in 2007, the guideline said avoid sugary drinks. And I want to demonstrate the difference here that in 2018, the guideline changed. And they changed it to say limit consumption of sugar sweetened drinks. Drink mostly water and unsweetened drinks. Well, in 2007, I was at the meeting in Bethesda when this was unveiled as a new guideline. And I went to the microphone and I said, there are sugary drinks and there are sugary drinks. You can drink a carbonated cola beverage, or you can drink a fruit punch, which is probably glucose and high fructose corn syrup, or you can squeeze 3 oranges in the morning. And the response from the podium was energetically, they're all the same. So I'll get to this in a moment. So again, in the French Nutrinet Santé study, a prospective cohort of 101,000 participants, they evaluated their consumption of sugary drinks that included 100% fruit juice, as well as artificially sweetened beverages. Most of the patients in France who were drinking sugary drinks were drinking fruit juice. And what they found, a positive association between sugary drink consumption and overall cancer. So the hazard ratio for 100 ml increase in sugary drinks was 18%. For breast cancer, it was 22%. Again, no association between prostate or colorectal cancer for sugary drinks. And there was, in fact, a positive association between 100% fruit juice increasing the risk of overall cancer by 12%. Artificially sweetened beverages here showed no increased risk because of the small sample size. Not many people in France were drinking artificially sweetened beverages. So sugar is a number one no. And when my colleagues who send me their patients to consult for integrative oncology interventions ask me, why do you tell all of our patients that cancer loves sugar? I answer, what's a PET scan? We inject people with radio-labeled glucose, and where does it go? To the cancer, because cancer requires sugar for energy. It doesn't use oxygen. So the guideline in 2007 again said limit consumption of red meats and avoid processed meats. They changed it in 2018 to say limit consumption of red and processed meats. Eat no more than moderate amounts of red meat, such as beef, pork, and lamb. Eat little, if any, processed meat. So again, avoid versus limit. I was on a webinar with the group from the American Institute for Cancer Research, World Cancer Research Fund. And the question I asked was, why did you change 2 guidelines from 2007 to 2018? Instead of avoid sugary drinks, you changed it to sugar sweetened beverages. Instead of avoid processed meats, you changed it to limit processed meats. And the answer was they wanted people to meet them halfway. Well, I think that's incorrect. I think that's opening the door to giving people the wrong recommendation and increasing the risk of cancer, personally. So this is a very old graph from an article by Walter Willett, Harvard's best nutrition scientist, showing the absolute linear relationship between red meat intake and colorectal cancer in women. And I say it's very old because now Japan and the Czech Republic have moved to the top of the list here. So the World Health Organization classifies processed meats as a class 1 carcinogen, no doubt about it. And red meats are probably causing cancer. Now, this is a graph that I show all of my patients, which many find quite disturbing. This is again from Walter Willett, New England Journal of Medicine, published 5 years ago. The article is on milk, and in the middle of the article, he has this graph of all-cause mortality, i.e. death, associated with protein sources. And the dotted line at 0 for reference is dairy, and below dairy is plants, poultry, and fish, and above dairy is red meat, eggs, and off-the-chart processed meats. So processed meats, high cause of mortality, and really should be avoided. I think the shocker for most of my patients are eggs, that eggs are second only to processed meats. I showed this graph to my personal trainer who eats 2 eggs every morning, and he found me an article published by Walter Willett extolling the health benefits of eggs. So I met Walter Willett in 2007 at the AICR meeting, and I sent him an email, Walter, eggs, good or bad? And I told him the story. And I immediately got back the message, I don't answer email, I get 3,000 emails a day. But he did respond. And he said, Donald, better than bacon, worse than walnuts. So everything is on a gradient, but personally, I don't eat eggs. This is a slide from my dear old friend, may he rest in peace, David Sayre von Schreiber, hence pork is spelled differently, showing the transformation of the food chain from over 40 years, from 1960 to 2000, showing the increased ratio of the omega-6 fatty acids, which promote inflammation, to the anti-inflammatory omega-3 in various food products. And again, you can see eggs are a major variant. I tell my patients if they're going to eat eggs, they should be organic omega-3 eggs. So is it the omega-6 excess that makes red meat a problem? Well, in addition, red meat has heme iron. Iron feeds cancer. How many patients do I see who become anemic from their chemotherapy and come to me and say, Dr. Abrams, I started taking an iron supplement because I'm anemic. I said, please stop the iron. Iron feeds cancer. That's one of the problems with red meat. Processed meats, of course, have nitrates, and those are positively associated with cancer. And then we live in a culture here on this side of the Atlantic where people like to barbecue their meat. And when you burn flesh, it creates heterocyclic amines, which are also carcinogenic. I'll have the half-pound double deluxe bacon steer burger, please. You want chemotherapy with that? So what is the best diet then? Seventh-day Adventists are a religious group that are usually some sort of a vegetarian. And they looked at vegetarian diet patterns and the development of colorectal cancer in 78,000 Seventh-day Adventists. 380 developed colon cancer and 110 rectal cancer after 7 years of follow-up. Adjusting the hazard ratio in vegetarians versus non-vegetarians for all colorectal cancer, there was a 22% decrease in the vegetarians. Interestingly, vegans only had a 16% decrease, and the largest impact was in the pesco-vegetarians, those who also ate fish. Colon cancer and rectal cancer were both reduced in people eating more vegetables. So I do not believe that vegan is a viable dietary life plan. I think there's no culture that's had vegan as their diet that's persisted. So I'm in favor of animal protein, and particularly I like deep cold water fish, salmon, black cod, albacore tuna, herring, mackerel, and sardines as the most rich in the omega-3 fatty acids, which are anti-inflammatory, a little bit antidepressant, and in Ayurveda, the medicine of India, they are considered a bowel lubricant. So here's another guideline that I actually think changed for the better personally. In 2007, it said, if consumed at all, limit alcohol to 2 a day for men and 1 a day for women. If at all, 2 a day seems quite dichotomous. In 2018, they changed the guideline. So it now says for cancer prevention, it's best not to drink alcohol, which is certainly easier to convey to patients. There's convincing evidence that alcohol increases the risk of upper aerodigestive cancer, of course, liver cancer, colorectal, and definitely postmenopausal breast. This graph showing you the relative risk of developing estrogen receptor positive postmenopausal breast cancer based on number of drinks per day. Probably increases the risk of stomach and premenopausal breast cancer, lung and pancreas, and interestingly, maybe decreases the risk of renal cell carcinoma. Michael Greger, who's a militant vegan, in his nutritionfacts.org video says, if even light drinking can cause cancer, why don't doctors warn their patients about it? And there was a suggestion in the New England Journal of Medicine a few years ago that maybe we should put a warning on alcohol, just as we do on cigarettes. So does it make any difference really to adhere to the guidelines? Again, the Nutrinet Santé cohort looked at 41,000 participants developing 1,489 cancers over 6.5 years of follow-up. And they found, looking at the World Cancer Research Fund, American Institute for Cancer Research guidelines, that a 1-point increment in the score, that is following one guideline more, led to a 12% decrease in the overall risk of cancer, a 14% decrease in the risk of breast cancer, and a 12% decrease in the risk of prostate cancer. In colorectal cancer, the confidence interval crossed 1, but it did seem to be a trend towards a decrease. A study from the UK Biobank published more recently looked at about 100,000 participants, and they were assigned adherence scores from 0 to 7, derived from their dietary, physical activity, and anthropomorphic data using the guidelines that we just discussed. The total mean score was 3.8. And during a median follow-up of 8 years, 7,200 individuals developed cancer. The total score was inversely associated with the risk of all cancers, 7% reduction per 1-point increment, breast cancer, colorectal, kidney, esophageal, ovarian, liver, and gallbladder cancer. So that's pretty good. Again, there was this surprising increased risk of head and neck cancers associated with greater adherence to the guidelines. Why that is, that's the second time we've seen increased risk of head and neck cancers in people who eat well. I'm baffled. So one more do from the guidelines is, as I mentioned, after a cancer diagnosis, follow our recommendations if you can. Doesn't make any difference. Well, I think a study by Jeffrey Meyerhart at Harvard, published quite a number of years ago now, looked at stage 3 colon cancer patients participating in an adjuvant chemotherapy trial. And what they did, they looked at their dietary patterns, and they looked at particularly the Western dietary pattern. And the group that had the lowest quintile of the Western dietary pattern had much lower risk of disease progression and death compared to the highest quintile. Those who had the highest quintile of the Western diet had a 3-fold increase of recurrence and a 2-fold increase of death. Well, what does that mean? Those patients over here had a daily serving of red meat, 5 refined grains, and 2 sugary desserts a day. Where these patients over here had red meat maybe twice a week, 2 refined grains a day, and a sugary dessert every other day. Interestingly, we use a lot now of immunotherapy. And this is a small study of 44 Dutch and 47 British immune checkpoint inhibitor patients who were about to start treatment with an anti-PD-L1 or an anti-cytotoxic T lymphocyte associated antigen. And what they found was positive associations between the Mediterranean dietary pattern, high in whole grains, fish, nuts, fruits, and vegetables, and the probability of responding better to the immunotherapy. And as we know, that's probably because this diet gives a microbiome that allows the immunotherapy to work better. So what is the ideal diet? It should be organic. Organic? Really? Again, Nutrinet Santé, très bien, mes amis. This is the population-based prospective cohort study of 70,000 participants, mainly women in this cohort. Participants reported their consumption frequency of labeled organic foods as never, occasionally, or most of the time, and an organic food score was calculated. After a mean follow-up of almost 5 years, there were 1,300 incident cancers, breast, prostate, skin, colorectal again, non-Hodgkin's lymphoma. High organic food scores were inversely associated with the risk of overall cancer. 25% reduction in the group that ate the most versus the least. Decreased risk mainly of postmenopausal breast cancer and non-Hodgkin lymphoma. There was no association for the other cancer types. But the authors concluded higher frequency of organic food consumption was associated with a reduced risk of cancer. I tell my patients that if a plant that's grown outdoors organically needs to fight to protect itself from other plants, birds and insects, and the sunshine. And the only way a plant knows how to fight is by making chemicals. Turns out those chemicals, the phytoalexins that the plant makes, are the phytonutrients that benefit us. So organic is more potent than conventional. Organic plant-based, so 5 to 9 servings or 3.5 to 4 cups of fruits and vegetables each day, but not vegetarian necessarily or vegan, antioxidant rich, real and whole foods. And this, in my opinion, is the basis of the anti-inflammatory diet. So again, as you know, I'm a big fan of cruciferous vegetables and heavily pigmented fruits. My major snack are blueberries. Whole grains, nuts, and legumes, also good for us. Decrease animal fats, minimize dairy, eggs, red meat, and avoid processed meats. Poultry should be organic to decrease the inflammatory potential and concentrate on the marine omega-3 fatty acids from deep cold water fish. Decrease refined carbohydrates, sugar, white flour, white rice. Brown rice is better than white rice, but if you like white rice, jasmine and basmati are best. Bread, if consumed, is preferably whole grain. Whole wheat is just heavily processed, unbleached white flour. Season with ginger, garlic, onions, and turmeric. The Mediterranean spices are also good: basil, thyme, rosemary, and oregano. And for beverages, think Christmas, green and red, green tea, and if you're consuming alcohol, which is not recommended, red wine would be the best beverage. So it was said long ago by Hippocrates, let your food be your medicine and your medicine be your food. And certainly I agree. So bon appetit.
Thank you very much for sharing this practical guidance to prevent cancers through nutrition. And so we know that changing habits is very difficult especially when it comes to health. This is also one of the missions of ONCIA communities to support complementary cancer care centers where patients, we give some nutrition counsels, cooking workshops in order to help people to change their habits. So thank you to all the participants. We are more than 50, and I let you send your questions through the Q&A button. We will follow up afterwards if we can cover all the questions today. But so let's start with the first question. So what is the best thing to take if you have an iron deficiency? Is blackstrap molasses a viable option?
I don't know the answer to that. I would say you should take an iron supplement if you have iron deficiency. Yeah, I just don't like patients taking iron if they're not deficient. So blackstrap molasses, I don't know why that would have iron in it, to be honest. I mean, there's heme iron in red meat. Again, I tell patients if they are iron deficient and don't want to take an iron supplement, that red meat is probably something to do. I don't believe beef or pork are ever going to be clean, and the only red meat I'll eat is lamb, because I picture roaming the hills of New Zealand or Sonoma County and not pinned up like beef and pork. And only eat lamb maybe once a week. or 3 times a month. I stay pretty much plant-based until dinner. But if you're iron deficient, that's an indication for taking iron.
The second question is, can you comment on ketogenic diet and fasting? Data from D'Agostino and Longo.
Yeah. So the ketogenic diet, I believe, is the least healthy diet out there. The Institute of Medicine in the United States suggests that 60% of our calories should come from carbohydrates, 20% fat, and 20% protein. By carbohydrates, I mean fruits, vegetables, whole grains, nuts, seeds, and legumes, and not bread, cookies, cake, and pasta necessarily. The ketogenic diet, unfortunately, in our country, we have a decrease in protein and carbohydrates and an increase in fat. And the ketogenic diet is all fat and protein and no carbohydrates. It was developed for children with epilepsy before we had anti-seizure drugs. I see no evidence that it can do anything for cancer. Uh, if people want to avoid sugar, that's, I think, produces the same milieu as ketogenesis. Fasting, Walter Longo at the University of Southern California is a big proponent of fasting, claiming that if you fast, it makes chemotherapy more effective against the cancer cells and less likely to damage the normal cells of the body. I think that's asking a lot of the diet. There is some evidence in women with breast cancer, if they do an overnight fast of 13 hours, they tend to have better outcomes compared to women who don't fast for 13 hours. I think the culprit is eating before you go to bed. I think after dinner you shouldn't eat and until breakfast. I don't like people skipping breakfast as part of their fast because I think breakfast is the most important meal of the day because it fuels us and it prevents us from eating too much at lunch if we get sufficient calories in the morning. So, I say I've been an oncologist for 42 years now, and I've cured many people of cancer who didn't need to fast. I will fast tomorrow for our Yom Kippur Jewish holiday, and it's my one fast day of the year. And it used to make me very groggy, dizzy, and cranky. Now, lately, when I fast, I feel better. So if you fast and feel better, then maybe it is something that's good for you. But otherwise, I don't necessarily recommend it to my patients with cancer to improve the outcome of their treatment. But if people are overweight and obese, you talked about changing habits and how difficult it is to change habits. And I agree. My colleagues here at the Osher Center are very impressed how much my patients change their diets. And I say, well, I think cancer is a big motivator for change. And I think it's important that patients get dietary information from the oncologist because oftentimes when the patient asks the doctor, the oncologist, conventional oncologist, what should I eat? The doctor will say, eat whatever you want. It doesn't really matter. And that's incorrect. So, so I'm not a big fan of the ketogenic diet, and I don't think fasting is mandatory, but I do recommend it for people who are overweight or obese. I must say that I do have frustrations with some of my overweight or obese patients who find it difficult to lose weight. Now, with these new weight loss therapies, I'm seeing very dramatic weight loss, but I just don't know how sustainable that is if they stop that treatment. So I think, again, fasting, if you want to try to lose weight, or if you're a woman with breast cancer, a 13-hour fast might be beneficial. But the ketogenic diet is not something I'm fond of. Yeah.
So we have another questions regarding sow consumption. So are there metabolism differences between Asian population and Occidental population that could explain different consequences of high soy consumption on breast cancer risk?
Well, I'm sure there are metabolic genetic differences between different cultural populations, but I don't think that there are different consequences of high soy consumption on breast cancer risk. I think we know that soy decreases the risk of both breast and prostate cancer. Asians living in Asia, eating an Asian diet, have lower risks of breast and prostate cancer. When they move across to Hawaii and start eating sort of a mixed diet, their risk of breast and prostate cancer increases. And when they come to the mainland of the US and eat the standard American diet, their risk becomes the same as Americans. So when I say a whole soy food, I mean soybeans, soy milk, tofu, tempeh, or miso, and not soy cheese, soy turkey, or soy hot dogs. Those are just heavily processed foods. So again, I think there's no difference in soy's benefit in Asian compared to Western populations. I see my friend Josh is asking questions about supplements. Hi, Josh.
Yes.
Supplements, I should come back and talk about that some other time. But when my patients ask me about can they take this supplement, it really depends on what their treatment is and whether the supplement is going to interfere with their treatment by way of impacting the liver that metabolizes pharmaceuticals or by the antioxidant effect. So we know that radiation therapy generates those free radicals of oxygen that are taken out of circulation by antioxidants. So we don't want patients receiving radiation or chemotherapy drugs that work that way to take antioxidant supplements. However, eating blueberries while you're getting radiation, I think, is fine because antioxidant-rich foods are not going to impact on that radiation beam.
So we have also a question regarding also from Joss Mailman about antioxidants usage prior to chemotherapy.
I just answered that one. Immunotherapy or
And
we don't know. Antioxidants are not going to impact immunotherapy, but as I mentioned, chemo and radiation, yes.
and monosodium glutamate.
Oh, monosodium glutamate? What about it?
Do you have
MSG.
some opinion about that?
I tend to avoid it, but I don't think it causes cancer, but it makes people have Chinese food syndrome.
Ask her to avoid turmeric due to her
Turmeric.
treatment. Is there a
Yeah.
situation where turmeric have to be avoided?
Yeah, so that's a very important question. We now have a pharmacist that I can send an electronic consult to. And most of the questions that I'm asking our pharmacists relate to turmeric because turmeric has a bad rap for being something that interferes with the liver's metabolism of pharmaceutical drugs. So whenever I've asked a question about potential interaction between a supplement and a pharmaceutical, it's always a turmeric question. I think cooking with turmeric is not going to impact anything, but taking a turmeric supplement, again, I'm not talking about supplements, is a higher dose and perhaps more heavily absorbed into the circulation. So it can, in fact, impact other drugs that are being used to treat the cancer. But for the most part, when I've sent these questions to the pharmacist, she said there's a theoretical concern, but it doesn't appear to be clinically relevant. Yesterday, however, I saw a patient who was on tamoxifen, and I think there is very good evidence that turmeric interferes with tamoxifen by causing it to be degraded too quickly, so that the dose of tamoxifen will turn out to be less than the dose that the oncologist is prescribing. So I told that patient yesterday, who was very proud that she was taking her turmeric, that she needed to stop it. But that's the only turmeric negative interaction that I've really been impressed by.
Do you recommend whole genome sequencing to identify specific cancer risk based on DNA and adapt diet accordingly?
I don't know. I'm seeing patients in consultation who already have cancer and who've already had all their genetic testing and their sequencing already done. So it's not something I do, and I don't adapt diet accordingly to patients' genomics. I think that for the most part, one size or the recommendations are pretty much universal.
What do you think about the protective effect of kefir and other fermented drinks for breast cancer?
Yeah, so in general, I'm not a big fan of dairy. There's no other animal that drinks another species' milk, but no other animal drives a car or goes to college either, so that's not a very good argument. But no animal drinks milk after they've been weaned, and by the age of 3 or 4, we actually lose the ability to digest the sugars and the proteins in cancer. We make a big deal in dairy. We make a big deal about fat, low fat, high fat, 2%. It's not the fat. If you want a dairy product, butter or ghee is probably best because it's mainly fat. We talk about lactose intolerance as if it's a disease or a disorder, when in fact it's the norm. And the ability to digest lactose is a genetic mutation on the second chromosome found mainly in Scandinavians who needed to digest reindeer milk in times of freeze. Otherwise, the rest of us, especially Asians, are all lactose intolerant and don't know until we stop. So then people always say, what about kefir or yogurt? So kefir or yogurt, the proteins and sugars have been altered by the bacteria. So if you need a dairy product, butter or ghee or kefir or yogurt, as long as they're not artificially colored, artificially flavored, and with added sugar. So with regards to impact on breast cancer, I'm not aware. Dairy is not necessarily good for breast cancer, but if dairy's not good, kefir is probably a little bit less not good, i.e. maybe better, but I don't think it decreases the risk.
What do you think about coffee?
So I haven't had coffee since I was 28, which was a number of years ago. I drink green tea. I think coffee is good for the heart and the brain, but it doesn't have the anti-cancer activity of green tea. And as long as people don't put two things that I'm not fond of, i.e. dairy and sugar, in their coffee, they're probably okay.
Do you do hormonal testing, such as Dutch?
I don't know what that means, such as Dutch. Yeah, no, the only blood test I order on my patients that I see as a consultant is a vitamin D level, because low vitamin D puts people at greater risk for cancer, and people with cancer whose vitamin D levels are low don't do as well as people whose vitamin D levels are normal. So there's not a lot of vitamin D in food. Deep cold water fish, ironically, are one of our best sources of vitamin D. And mushrooms, if you put mushrooms in the sunshine, they will generate ergocalciferol, vitamin D2, not as potent as vitamin D3. All mushrooms, by the way, must be cooked. Slicing white button mushrooms and throwing them in a salad is a no. White button mushrooms have a cancer-causing compound in them. So all mushrooms must be cooked. White buttons, their brown cousin, the crimini, and their giant cousin, the portobello, may have some aromatase inhibitor activity, but must be cooked.
Can you comment about the AICR's continuous update projects for colorectal cancer that found a protective effect for dairy consumption?
Yeah, I wrote an editorial on that for the Journal of Clinical Oncology a number of years ago when another prospective study suggested dairy might decrease the risk of colon cancer. Personally, I think it's the calcium, and I don't know that dairy is our major source of calcium in the diet. So I think it's well known that both calcium and magnesium decrease the risk of colorectal cancer. And since dairy is the major source of calcium in the diet, I think it gets the pat on the back. I did write an article with a dietitian published about 2 years ago on dairy and cancer, and we enumerate all the malignancies that seem to be associated with dairy consumption.
The other question is regarding, yes, do you have ever have patients con daily fibers, for instance, 30 grams daily, while on immunotherapy, given what we know about the gut microbiome benefits?
I'm not that quantitative, so I don't necessarily ask patients to quantify their calories or their intake of fiber. And again, I'm a consultant. I'm not their primary oncologist, so it's not something that I generally do. I recommend the diet that I recommend and hope that it's going to provide them with the amount of fiber that they need.
Any advice for someone who's allergic to fish or nuts? What are the best replacements?
I don't know any replacement for nuts. For fish, the omega-3s, I think there are vegan sources of omega-3s that are available. But, krill oil, and there are vegan omega-3 sources.
And the last one, do you test your patients for insulin resistance?
I do. Again, the only blood test I can order here is a vitamin D level. The way it works in my clinic, if any blood test I order, I have to associate with a diagnosis, and I can't even order a hemoglobin A1C unless a patient is pre-diabetic or diabetic. So, plus, I don't order these tests because I'm retired. I retired 5 years ago, and I only work 2 mornings a week doing my integrative oncology consultations, and I don't want to have to follow up and manage a patient who comes back with a high hemoglobin A1C. So I would ask their primary care provider to check that and advise the patient accordingly.
Okay. So the webinar is coming to hand. Thank you very much for your presentation, for your capabilities. So for the attendees, so you have to know that the webinar was recorded and the replay will be available on our website. So stay tuned for our next webinars. It's on a quarterly basis. The next one will be in December. We will send you the topic soon. And see you soon. And thank you very much, Dr. Abrams, to be here with us today.
Bye bye.
Bye. Goodbye.